Hello and good evening, everybody. Thank you for joining Field Trip Health on this webinar on psychedelic-assisted psychotherapy. Predominantly, this talk tonight is predominantly geared for people who are working in the mental health field, be it nurses, mental health professionals, psychiatrists, family physicians, or other doctors. However, there's a lot of great information, so I anticipate that our audience will be a lot broader. If you look to the right, you'll see that there's a chat section and there might be some poll questions that come up. So feel free to answer those if they come up, and you can also write any questions, and hopefully towards the end of this webinar, I'll be able to address some of them. I also have a guest joining me later, which I'll introduce at the time. So I'm going to share my screen now, and I look forward to a great evening, and thank you again for taking the time to be here with us. Okay, so tonight we're going to talk about psychedelic or ketamine-assisted psychotherapy. Okay, I'm Dr. Michael Verbora. I'm the medical director at Field Trip Health. A little bit about me. I have a degree in biochemistry from the University of Windsor, followed by my master's of business at the Schulich School of Medicine. I did my medical degree and training at Western University, and then I went on to family medicine training at the University of Toronto. I'm the medical director of Field Trip Health, as mentioned, a mental wellness company focused on psychedelic-assisted psychotherapy. I'm also the chief medical officer of Alephia Health. This is a medical cannabis company. I'm an assistant professor adjunct level at McMaster University, and I also do student health, and I'm a professor in cannabis education, and hopefully soon psychedelic education at Seneca College. So I'm not sure how many people are aware of what's really happening in the world today with respect to mental health, but there's this movement, and the movement is driven by patients. It's driven by new innovative drug policy, and it's driven by research and evidence coming out on old drugs that are typically highly stigmatized and politicized. And the evidence coming out is pretty remarkable. And so we're really at this paradigm moment, or this transformational moment, where the shift is happening. And we're leaving this current approach of giving patients take drugs every day, like typically antidepressants, and blunting their emotional response to, their anxieties or their depression through these drugs, which is very passive, to a transition into this more emotional work, which is helping patients break through some of the pain, suffering, traumas, narratives that they have that kind of hold them back from living to their full potential. And really this paradigm shift is taking place with the use of psychedelic drugs. And so we're getting away from blunting and taking a pill every day, which is a passive approach to emotional health, to processing, transforming, actively engaging with who we are that makes us who we are, and trying to push through this with these drugs to heal. And so this transition is taking place as we speak. And I anticipate in the next 5 to 10 years, you're going to see a complete revolution in the way that we approach mental health. The agenda for today is going to include the history of psychedelics, a little overview of some of the most popular psychedelic drugs, the risks and harms of psychedelic drugs, and then we're going to focus specifically on ketamine-assisted psychotherapy as well as IV ketamine. Talk a little bit about that renaissance in psychedelic research that's taking place, take a peek at what the future is likely to look like, and then we're going to share a little bit about Field Trip Health and what we have to offer as a mental wellness company. So first, we should talk a little bit about psychedelics. Now, if you asked me about 5 years ago when I was in medical school or residency training, what did I think about psychedelic drugs? I was very uneducated. I was very misinformed. And, some of these images of, psychedelic visuals kind of would come to my mind at the time. And I never really understood what, the benefit was, whether that was recreational or not. And I didn't know if they were dangerous or not dangerous. I just got the impression from my medical training that it was an illegal drug, so it probably caused more harm than good. And that was kind of my assumptions and part of maybe my medical training that convinced me of that. If you ask me today, after I've taken the time to listen to patients who've used psychedelic drugs, I've had immense experience dealing with patients with severe mental illness as well as chronic pain. And, I've read the literature now coming out across the world on psychedelic drugs. I have a completely different impression of what psychedelic drugs are. And for me now, psychedelic drugs are just tools. They're tools, when used properly with psychotherapy, can rapidly change the way that people look at themselves and the world. And that's really exciting because we don't have drugs today or therapies available that can rapidly help people. All of the drugs and therapies we have take, at least 6 weeks often to kick in. So to have a drug that can be transformational in a short period of time, I think is going to save a lot of people. And so I have a complete different view now on psychedelics than I did 5 years ago. And I anticipate the whole world is slowly going to shift. Just as we see with cannabis, a lot of opinions shifting. So what is a psychedelic? So really this word can be broken into two, psyche and delune, which really means mind and soul, and manifesting or revealing. And so psychedelics are a mental state characterized by a profound sense of intensified sensory perception. Oftentimes it comes with visual distortions. We can call these hallucinations, and they can lead to extreme feelings of either euphoria or despair, okay? There's a expression in the psychedelic community and for those who use psychedelic drugs, and that is that you might not always get what you want from a psychedelic experience, but you often get what you need. And there's sometimes a bit of a misconception that all psychedelic experiences are just blissful and mystical, and that they're nothing but beauty. And that couldn't be further from the truth. While many times it can be that way, there's often many times where the psychedelic experience for patients is actually very difficult, very intense in emotion, reliving of traumas. That it can be very painful, but it's through these experiences in a very complicated, twisted way that we don't fully understand. A lot of tension releases, a lot of pain releases, and people seem to be lighter and breathe better and not carry the same emotions with their past experiences. I'm going to shift gears and talk a little bit about the history of psychedelics. So, when you say the word psychedelic, honestly, thousands of different compounds can really be characterized and classified under the term psychedelic. These are the most common, most mainstream psychedelics, but theoretically, you could create thousands and thousands of permutations of psychedelics in a laboratory. But yeah, a lot of these drugs go back years and years and years ago and have been used historically, in Amazon cultures such as ayahuasca, which we still use today and often in South America still, and there's associated rituals with these drugs and healing ceremonies. And there's a lot of wisdom that, shaman or healers have that we're trying to understand. There's something there. And, ayahuasca is just one of many drugs. There's a whole history around LSD, which is a synthetic molecule that was synthesized in the lab. And, that eventually led the lab, and in the 1950s and 60s created a bit of a psychedelic movement. Psilocybin is probably one of the most popular known magic mushrooms. It's a drug that's being studied today across the world for issues like anorexia or depression or end-of-life anxiety. Drugs like MDMA, which is, the club drug, the rave drug, that's being used now for post-traumatic stress disorder. We have close to over 100 years of experience with these drugs. So there's all these different psychedelics, and they have complex histories. One of the things they tend to have in common in many countries is that they're illegal, or they're regulated or controlled and have a certain scheduling that do not make them accessible for researchers. And despite that, there are different mechanisms by which certain types of research can be sponsored, and certain agencies can grant permissions to individuals to study it, and that's what we're seeing. But by and large, a lot of these drugs are typically illegal. Mind you, as of just what was the election a week ago? As of a week ago, psychedelic drugs in states like Oregon are no longer illegal, and they're decriminalized, and they're moving forward with a medical program. And so in the next 2 years, we're going to see a medical program starting to, blossom into, hopefully different states and hopefully different countries across the world. And so we're going very rapidly, again, like we did with cannabis, from, a little bit of knowledge and research and experience with patients to rapidly medicalizing these drugs. And I think, the world really needs it. I think patients really need another option. I meet many, many patients who are treatment resistant, have failed so many therapies. So to have more options and to have good data to be able to give them the right medical knowledge and proper use patterns is so important. So in the 1950s and 60s, what a lot of people don't realize is that there was immense research that was done. Over 1,000 scientific papers were published on LSD. And a lot of these showed the same thing, that it was effective for a whole host of mental health disorders, and it was extremely safe. People didn't overdose. People didn't typically die from taking this drug. It typically was safer than a lot of the drugs we use today. But despite that, because it left the lab and caused a lot of tension in politics and it disrupted the social fabric, these drugs were made illegal, not based on science, but based purely on politics, right? So this was, the 1960s where these drugs started to become prohibited. And so there's a whole history of these drugs. And it's really important, as these drugs once again come into mainstream, that we kind of pause and have great intention, because, we'd hate to repeat the same mistake we made before. So I anticipate this round with the renaissance in psychedelics, it's going to be a little bit slower. It's going to be a lot more medical. You're going to see, niches start to pop up, certain drugs for certain, medically defined disorders. And then maybe there'll be regions or hotspots where drugs will be decriminalized or legalized slowly, and it'll be permitted for recreational use. However, I anticipate the whole process is going to be a little bit slower. And I hope that we really just pause and take the time to collect as much research as we can. Because if we really want these drugs to be, accessible for the vast majority of people, it's going to be really important to collect the evidence and research that we need. Okay, I'm just going to pause here for 1 second. I want to make sure everyone can see my screen. Okay, so I've been chatting for a while and I think people missed my screen. So I sincerely apologize. Okay, so hopefully my words carried enough. I hope everyone can see my screen. Can someone just text me to confirm that they can see my screen? I'll just check the chat box. Looks good. Okay, my sincere apologies. Okay. So you didn't miss much. So this is probably the most important slide that I'll just kind of go back to, which really just shows where these drugs were discovered across the world and the historical use. So I apologize, you had to stare at my face this entire time. Okay, so we're here now at the utility of psychedelic drugs. So there's really a wide range of utility for these psychedelic drugs. Now, we typically think as medical practitioners of the medical uses, but it's important to recognize that people use these in a recreational fashion. And just because somebody uses a drug in a recreational way doesn't necessarily mean that it's, self-harming or harmful to the individual. It's a lot more complicated than that. People use psychedelic drugs for spirituality, and people also use them for healing. Now, this is a really interesting publication. If people are really interested, and I apologize for the quality of it from this study. If you're really interested in learning a little bit about the history of psychedelic drugs, this paper really kind of outlines that, going back to before 1900. So there's a ton of research that's already been done. A lot of it really been done on LSD, a synthetic drug, and how it modulates serotonin. And so we actually know quite a bit about it. And then ketamine is a drug we're going to spend a lot of time talking about. And ketamine is very interesting because it's a synthetic molecule that has psychedelic properties. Okay, so what are some of the psychedelic drugs? There's no agreement, I would say, amongst professionals or experts about how we should really divide or categorize the different ways that psychedelic drugs work, because no two psychedelics typically work exactly the same way. But we've kind of classified them into whether they are serotonergic psychedelics. So that means that they bind to the serotonin receptor or one of the serotonin receptors, okay, because there's more than one. Or empathogens or entactogens, which cause the release of serotonin into the synapse, which then binds. Dissociative drugs, which are typically your NMDMA receptor antagonists, or even cannabinoids. So cannabinoids, I think, will ring a bell. Those are your THC molecule, which binds to CB1 in the brain. So this is just a random nomenclature. It's not the most definitive, but it's just a way to help categorize and think, how do all of these different psychedelic drugs work? How are they similar, but also how are they different? And we can just look at where they're binding essentially in the brain and how that might represent different effects. So LSD falls into that first category, that serotonergic psychedelic. It's a synthetic drug designed in a lab. People typically experience hallucinations. The effects can last typically up to 12 hours. A lot of data has been collected that does not show it to be addictive. And what's really remarkable is its penetration. About 10% of people in the US have tried LSD at some point. DMT is really a remarkable molecule. Some people call it the spirit molecule because humans do synthesize this in small amounts. And it does occur naturally in humans, plants, and animals. And, the drug ayahuasca has, when combined with certain plants, releases DMT, and it's been used historically for spirituality. It has rapid onsets, rapid effects, and it's, I think most people would consider this to be a very potent psychedelic. Psilocybin, we talked a little bit about. This is your magic mushrooms. It actually shows up in over 200 different types of mushrooms. When you ingest it, it goes into the stomach, converts into a drug called psilocin, which does most of the effects. Again, all of these first three drugs are all serotonergic. They all bind to the serotonin receptors. Again, psilocybin, a lot of recreational use out there. But again, a lot of people using this for depression now, whether it's microdosing or macrodosing it. It's being extensively studied today. It's probably one of the most researched psychedelics. MDMA is a different drug, so it doesn't necessarily agonize the receptor, but it releases a flood of serotonin into the synapse for binding. This is ecstasy involved in the rave culture. Its effects can last up to 8 hours. It's extremely intensive and very hard opening. Okay. Moving on, a couple other drugs. So THC. So a lot of people will argue that cannabis is not a psychedelic. Some people argue it is. I think that's semantics. THC is a different category. It's a cannabinoid. It's found in the cannabis plant. It binds to receptors in the brain and the immune system. If you inhale it, you're getting delta-9 THC. If you ingest it, it's being converted into a drug called 11-hydroxy-THC, which might be even more psychoactive depending on the dose that you take. It does regulate homeostasis in the body, and I do believe it to be a mild psychedelic is how I would classify it personally. Peyote as well is, again, a serotonergic. It's found in cacti, most commonly mescaline. It's known as the divine messenger. It's used by indigenous communities around the world. And then ketamine is really interesting. It's the one drug that falls under that category, dissociative. So it's an NMDA receptor antagonist. It's a synthetic drug designed in the 1960s. And what was remarkable about it is we used it a lot in wartime, and soldiers would carry this onto the battlefield. And if, the guy next to them went down, they would give them an injection of ketamine because it was considered to be safe. It didn't stop individuals from breathing, but it anesthetized them and stopped their pain response. But we noticed that, today we use it every day, like in emergency rooms, for example, in high doses to sedate people for anesthesia, whether it's, a child who broke a wrist and needs to have it set. We'll give them a dose of ketamine to help them forget and also to anesthetize. But we found that, over 20, 30 years ago, that if you give people lower to low medium doses, you get a dissociative effect. And that actually has a lot of antidepressant effects. And it's actually quite safe. So you typically can't overdose on it. It doesn't, suppress your drive to breathe, like opioids, for example. And what's nice about it is that it's about 45 minutes to an hour. So a lot of those other psychedelic drugs we talked about, the effects can last 4 to 6 hours, which can be a lot for many people. So ketamine, what's attractive about it is also that onset and duration. Okay, so we're going to spend a little bit of time talking specifically about that. So now I'm going to kind of dive into the risks and safety of psychedelic drugs. And so if you just came to this world today and you heard that all these psychedelic drugs were illegal, or most of them, you probably think, well, they must be the most dangerous drugs ever, right? Because, why would people ban these drugs if they were safe? But the reality is that psychedelic drugs are extremely safe. So this was a great study done by Dr. Nutt in the UK, who used to work for the government, and he was commissioned to do a lot of research on drugs. And lo and behold, he discovered that, a lot of the illegal drugs are not harmful and a lot of the legal drugs are harmful. And so, without a shadow of a doubt, alcohol is by far the most harmful drug that we have in society. And that's with respect to two categories: harm to the self when using and harm to others. As you move down this list, this graph, so if you start at the top, it's the most dangerous, and you can go all the way down. You can see drugs like mushrooms, which is psilocybin, LSD, ecstasy, ketamine. The probability of somebody hurting themselves with these drugs is extremely low, and the probability of them hurting other people is actually extremely low, right? And same with cannabis up here as well. So this is what's really remarkable, is that from a perspective of harm, most psychedelic drugs are quite safe. And so it's nice to see, decriminalization of these drugs, and it's nice to see a lot of research being done, because not only are they typically safer drugs than we allow people to buy without a prescription, they actually have a lot of medicinal value, and so they can actually help a lot of people. So there's a flip side to this. So what does that flip side look like? Well, the potential benefits that we've learned from a number of studies now on psychedelics, and I'm kind of categorizing them all together because they do have a lot of overlap in terms of what they do to the human brain. But the number one is probably enhanced mental flexibility. And I didn't spell mental right, it looks like. So patients generally will have an increase in neuroplasticity, so more connections to different areas of the brain. And the way that I really describe this to patients is that you're getting more bandwidth. You're getting more lanes on your highway to deal with a wider range of circumstances, emotions, interactions. And that's really, really helpful, right? Which that can manifest into antidepressive, anti-anxiety effects. And it really can facilitate a lot of healing or trauma work. And trauma is something that we don't have, exceptionally good therapies for. Like, we do intensive therapy for people who undergo trauma, but it takes years and years often. And we don't have strong, good evidence-based pharmaceuticals to help people with post-traumatic stress. And ultimately, what a lot of these psychedelic drugs do is they reprogram the default mode network, which we'll talk about. Now, what are the risks and side effects of these drugs? Well, it's important that if you're doing these drugs, that they be done in the right setting. So your mindset and the right setting is important, which again, we'll talk about. People do experience sometimes temporary anxiety or worry, and that can last as little as 10 minutes. It can last longer depending on the psychedelic drug you take. Experiences, like I mentioned earlier, are not always simple, not always blissful, not always easy. They can be very difficult. Physiologically, we see slight changes in heart rate and blood pressure, but rarely do we have to intervene in psychedelic experiences. One of the caveats to all this, though, is that we don't really understand the long-term risks. But that really, you have to take that long-term risk, because a lot of people, who are, anti-psychedelic, anti-cannabis, they bring up this long-term risk issue a lot, which is absolutely fair. But we don't really know a lot about long-term risks of a lot of pharmaceuticals, right? A lot of pharmaceuticals are brought to the market after just a couple of studies. It's not like you have to use these drugs for 10, 20, 30 years to get a drug approved for use in humans. So, we have to kind of look at the tools that we have in the context of how we accept drugs and kind of, level the playing field. So while we should look at the long-term risk of all drugs, reality is we don't know a lot of the long-term risks for many drugs. So the default mode network, that was something that I brought up. And I want to talk a little bit about it because regardless of the psychedelic drug that patients use, there tends to be dramatic changes in this area of the brain. So what is the default mode network? Well, it's a network of brain regions that are active when the brain is supposed to be at rest, if there's such a thing as your brain never resting, right? It's a number of sections that tend to light up together. And when your mind is wandering or also ruminating, these areas tend to light up on a functional MRI scan, as you can see in that photo. It's communicated with language and speech areas, and it's probably responsible for some of our internal monologue. And what we notice is psychedelics loosen this network, or loosen maybe perhaps the ego is the right word to use. And this looser network increases your entropy. And so what we tend to see is more of an infantile consciousness, more creative, more divergent thinking, And this is very contradictory to what we would call a very rigid default mode network, where it's low entropy. And these rigid default mode networks are associated with addictions, obsessive compulsive disorder, rigid thinking, depression, okay? And when we totally shut this area off, which often happens in certain psychedelic experiences, what we call transformational experiences, a lot of patients will undergo ego dissolution. So a strong disconnection from, the parts that they identify with. And that temporary break gives them an opportunity to perhaps pause on, their own identity and come back with different pieces and come back with new learnings to perhaps, become a little bit different version of themselves and perhaps a better version. What's really remarkable to me is this is a research study, a publication, and the left is, this is your brain on a placebo, and the right is, this is your brain on psilocybin, a psychedelic. So what you're seeing here is scaffolds in the brain and how different areas of the brain communicate. And so what you're seeing is a ton of interconnectivity. And so the brain likes to learn its pathways. And, when you're a child and you're young, you're making all of these pathways. And at any point in time, you can have a new experience when you're young. And because your brain is so plastic, you can learn something completely new and connect different areas of your brain. But as you become older and more stubborn, let's be honest, these pathways become a little bit rigid and it's hard to loosen them. And so we get kind of stuck in our thinking. And sometimes that could be very pathological. And so what these psychedelic drugs do is they really open up the network, give you a bright new opportunity for neuroplasticity. And a lot of our assumptions, our beliefs can kind of be questioned, which is actually healthy to do from time to time. Okay, I'm going to shift gears and talk a little bit about ketamine now. So ketamine is really the only legal psychedelic drug that we can use here in Canada outside of research. So unless you're doing research with a psychedelic and have an ethics approval to do so, you can only really work with ketamine. And this drug was invented to be safer than the typical anesthetics at the time in the 1960s, because a lot of anesthetics suppress your ability to breathe, right? So you need an anesthetist to help you breathe during surgery because they give you anesthetic drugs that stop your ability to breathe. But ketamine's different, doesn't do that. So like I mentioned earlier, we use it all the time in children, we use it in animals. It's considered relatively safe. In Vietnam War, it was carried as that buddy drug to inject in the guy next to you if something bad happened. It works on a whole host of areas, such as or neurochemicals in the brain, neurotransmitters such as serotonin and dopamine. But the most predominant one is glutamate. And glutamate might really be that master regulator of the brain. It's really an abundant molecule that regulates so many different neuronal pathways for all of our mental health needs. In 2000, so we're talking 20 years ago, we actually discovered, and probably even dates back earlier than that, but 2000, there was publications that demonstrated low doses of ketamine are antidepressant. We have research now that shows ketamine can help with pain, depression, migraine headaches. In the US, there's actually, and now actually in Canada, as of just a couple months ago, there's an approved ketamine nasal spray for depression. And so that's actually an option now for treatment-resistant depression here in Canada. How ketamine works is it really allows for a temporary dissociation. So people temporarily, float or temporarily disconnect from all their normal patterns of thought. And that 1 hour break is extremely therapeutic. And then they come back, they always come back. And they just come back with a different perspective or different opportunity. And it's really what happens in the next couple of days, in the next couple of weeks, which is why it's so important to have therapy when using these psychedelic drugs. Because what happens in those next couple of days, couple of weeks, when that neuroplasticity window is open, is what's going to determine the long-term outcomes of your psychedelic use. And there's nothing worse than taking a psychedelic drug, having all of these beautiful insights and realizing that you can, take control of so many things in your life to live a better life, only to not have someone coach you, be there, present, maybe be accountable towards you, and to help guide you through it. So then you do a psychedelic again, and then you just kind of get the same message over and over again. And so there are missed opportunities. So it's really important, in my strong opinion, that psychedelics be paired with psychotherapy. And that's where all the research is, right? All the research coming out is not just take a psychedelic drug and see if it works. It's take a psychedelic drug, do psychotherapy for a set amount of time. And that's what's being proved as a model to work. Okay. This is a complex slide. It's really just for, brain nerds who are really interested in what's taking place in the brain and how this neuroplasticity window is open and what's taking place with glutamate. It's extremely, sometimes it's a little bit over my head, but you can see there's brain-derived neurotropic factor and mTOR. These are molecules that, new nerve cells make. So essentially the use of ketamine is increasing, these peptides that show new nerve pathways. And so this is what leads to essentially new brain connections. And so it's pretty remarkable how that takes place. It's extremely complex, right? The human brain is still something I think that we know like 1% about. I think we really have so much to learn about the human brain. And what's amazing is that we're going to use psychedelics and help the human brain. At the same time, it's going to teach us so much about the human brain. So there's a lot of research that shows ketamine has proven to be neuroplastic. And then there's a lot of research as well demonstrating that this takes place, particularly in treatment-resistant depression, that you get this opportunity to help the depression through this pathway. Okay. So there's really two different approaches to using ketamine today. There's, what I would call the biomedical approach, which is you get ketamine in an infusion, and there's a lot of scientific evidence, what we call randomized controlled placebo trials, that demonstrate an infusion of ketamine over about 40 minutes. Usually it's about 6 sessions over the course of 2 to 3 weeks. Intentionally, they try to avoid you can call it a side effect of dissociation. And that's what they do. There's no therapy involved. There's no coaching. There's no transformational experience. There's no psychedelic state. It's very passive. You sit in a chair, you get a little bit of ketamine, and we hope the drug helps you. Okay, this is what we've been doing for the last 50 years in Western medicine. And then there's ketamine-assisted psychotherapy, which is a ketamine injection or a lozenge. The experience is 40 to 60 minutes, sometimes a little bit longer. And we don't necessarily shy away from dissociation. We still start at low doses. We want to see how your body responds to it, but these are usually over 6 sessions. And as we start to increase the dose, what the science shows is that dissociation is correlated to clinical outcome. So as much as we want to take away dissociation and reduce that side effect, it's probably a necessary component to maximize the results of the use of ketamine. Okay? Now, the biomedical approach is still valid. It still probably helps many patients. But I think with time, we're going to see that the assisted psychotherapy model is by far a superior model. But nonetheless, this is a number of studies here listed in the top right corner that show that, IV infusions of ketamine, they work relatively rapidly, that there is evidence that it does help with remission of severe treatment-resistant patients. So it's really important to note that ketamine's actually been predominantly studied in the most debilitating forms of depression. So it's not just typically major depressive disorder, which is much more common, but it's treatment-resistant depressive disorder. So where patients have already failed at least 2 drugs. Okay, so this is a different class of patients who, their depression is typically more severe. And again, this increases plasticity. We see changes in brain patterns. Suicidal ideation decreases. Cognitive deficits that are caused by depression also decrease or reverse. And what we see as far as that benefits typically last 4 to 10 days, but there might be a cumulative effect. And again, this is probably where the therapy comes in. If you want to increase the effects of these therapies, of these drug therapies, I think having a psychotherapist is very important to do that. What are the risks of ketamine? Well, this is a study published in Lancet Psychiatry. So short-term, when you use ketamine, there's a slight increase in blood pressure, increase in heart rate. Certain types of populations shouldn't use it. So high blood pressure, heart failure, or a history of stroke. You can get headaches, nausea, vomiting, sometimes drowsiness, anxiety, or dizziness, okay? There's a rare issue with long-term chronic, what I would call recreational use of ketamine. We only find it in recreational users, and that's what we call ketamine bladder, where people get inflammation of the bladder or cystitis. And it's really seen in recreational users. I can tell you in our clinic, I haven't had any patients have any symptoms. But it might be a relative contraindication. So if someone already has chronic cystitis, not necessarily from ketamine, you might want to be cautious about giving them ketamine or just monitor for it. And if you use too much, because it's metabolized by the liver, there's always a risk of hepatotoxicity. Ketamine does affect, it does, for some people, it's pleasurable. It does regulate dopamine. So there's a little bit of abuse potential as well there, but nowhere near a lot of the other drugs that we use. So the ketamine IV protocols used at IV clinics are really based off of two major studies, which are listed below. One is a randomized trial for treatment-resistant depression, where the science showed that 71% of patients had a response and about 30% were in remission after following infusion. And again, this is for treatment-resistant depression, so the most severe form of depression. And then this study was a double-blind randomized placebo-controlled trial with, again, IV ketamine and, again, treatment-resistant depression. They followed the electroconvulsive therapy protocol. Now, this is kind of what we do clinically, is we follow that ECT protocol. It's completely arbitrary, but what the science was done on. And so it's 2 to 3 times a week for 2 to 3 weeks, so typically 6 sessions. And again, this study showed clinical significant changes in depression. Patients tolerated the drug with side effects mostly minor. Okay. And what's really interesting here is that there's a bit of desensitization. So as patients took more and more ketamine, the dissociation tended to decrease a bit. Okay. Now, this is a different model that I want to talk about, KAP or CAP, which is ketamine-assisted psychotherapy. And this is really to use a molecule to facilitate psychotherapy. And this is really associated with a lot of wisdom out there. And Stan Grof, who, is quite a remarkable individual and a long time, physician who's been helping patients use ketamine or other psychedelic drugs, really believes in this inner healing intelligence. And what that is that we all have a blueprint in us that can guide us to where we need to be for healing. And each of us has a different blueprint, but how to access that blueprint often slips our hands in this busy, sometimes crazy world. So how do we use these drugs to open up our minds with therapy to access our own inner healer? And that's the model that we believe in at Field Trip Health. This model is typically delivered by preparatory psychotherapy sessions to make sure you're prepared. We're not going to just give you the ketamine if you're not in the right mental state for change. We target a certain number of drug sessions, and we don't shy away from dissociation. We don't try to encourage dissociation right away. We slowly and intentionally increase the dose with time, and we monitor, and we recognize that no two patients are the same. Some patients will have very good effects at very low doses and will stay there, and other patients will need higher doses to get more meaningful effects. But we work with our patients. We listen to their experience. And then we integrate what happens in their psychedelic experiences or their drug sessions, and we do what's called integration sessions, where we try to understand for them what is the learning opportunity and how can they change their day-to-day life to make meaningful change for the long term. So that's how our model works. We're extremely proud of it. It's been designed by a whole host of experts in psychiatry, mental health, and we're going to show you some data as well later, talking a little bit about what we're seeing in the clinic. What's really important to the model of assisted psychotherapy or drug-assisted psychotherapy is that set and setting are so important. And this is not something that you talk about in medicine. At no point in my medical training did anyone say, well, it matters when you take a drug, what mindset the patient's in, or it matters where the patient's taking the drug. Never once have I ever been told that my environment or the individual mind state could affect a drug experience. It's not until I started doing research and understanding that, well, you could take the same drug in 2 totally different settings, get 2 totally different experiences, right? If you take MDMA, at a rave, it's gonna be very different than taking MDMA with a therapist to work through your trauma. It's 2 totally different settings, 2 totally different environments. You're going in it with 2 totally different intentions. So it's just so important. And that's why we built out specially built clinics for setting control. And it's so important that we do therapy to maximize your mindset and make sure that you're ready for it and there's no pressure. Okay. So what is the evidence on ketamine-assisted psychotherapy? So it dates back to as far as 1971. These aren't high, excellent quality studies, but nonetheless, it's still evidence showing that we've actually known for 50 years that ketamine with psychotherapy can help. So in 1971 in Mexico, 85% of patients who did ketamine with psychotherapy had positive outcomes. 1973, Iran, 91 patients out of 100, 91% were doing well or better. In Russia, they did a randomized controlled trial on alcohol and heroin dependence. They gave ketamine to 500 patients, and they saw abstinent rates were quite high, 22%, and even 50% at 3 sessions in 1 year. But really, it wasn't until a number of years ago, just a couple of years ago, that a big, relatively observational study came out with more of a modern model of ketamine-assisted psychotherapy, an observational study. And they looked at 3 different practices in the US, 235 patients treated at 3 different sites. And they did, again, ketamine plus psychotherapy, and it was either sublingual and or intramuscularly. And they demonstrated that there were significant decreases in symptoms, specifically in certain groups, such as severely sick as well as elderly. And the more severe the depression or the anxiety, the greater the response with ketamine psychotherapy. There's, it's not all perfect. All drugs have side effects. 1 to 5% couldn't tolerate the drug. So unfortunately, they couldn't use the drug further after 1 or 2 experiences. And 1 to 2% just didn't respond. Oh, sorry, I'm jumping way ahead here. So this is kind of a summary of that study, just a chart showing, what the average depression scores are. So higher here is more depressed, lower is less depressed. So this was before ketamine-assisted psychotherapy, and this was after ketamine-assisted psychotherapy, and there's 250-ish patients, and this was anxiety. And these were determined to be clinically significant, okay? So proof that the hypothesis is very likely to be not just random, okay? So now I'm going to shift again and talk a little bit about the broader psychedelic-assisted psychotherapy and a little bit more about mindset, setting, and what it looks like and feels like, and what probably the future is going to look like with psychedelic-assisted psychotherapy. A lot of patients who don't have psychedelic drug experience, who come in and we talk about ketamine and they qualify for ketamine for their mental illness. A lot of them want to know, well, what am I going to experience? What am I going to feel? And we can't concretely tell you because each person has different experiences. And so no 2 trips are really the same, or no 2 journeys are the same. But we do emphasize and optimize set and setting, mindset, as well as the physical environment. But there's a lot of common themes that we see over time, and that's the sensation of rebirth, experience of dying or having a near-death experience, dissolving of the ego, mystical experiences, spiritual awakening, immense insight into life's true priorities, sensation of oneness. And, sometimes things seem really simple, like, I need to sleep better, or I need to start exercising and moving. And it sounds so simple and you kind of know it, but it's not until you go through the psychedelic experience that it feels real and meaningful and that you really are invested in it now. Lower doses of ketamine can be a little bit trance-like. We call that relational dosing. Medium doses are more mystical, which we can potentially push into what we call transformational, so potentially transform someone. And what we see is that magical solution thinking can be really powerful for changing our behavior. Are the psychoactive effects necessary? So I alluded to this earlier. And so they actually did a number of studies, and it's obvious based on the literature out there that, many people tried to take psychedelic drugs and pharmaceutical companies try to get rid of the side effect of dissociation, and then the drugs just didn't work. So, as much as we want a drug that, looks, feels, and tastes like water and magically heals us, the reality is that if you're going to get meaningful change out of a drug experience, it's probably going to be a profound experience that's going to be intense. So I believe, and the evidence shows that, this dissociation, this sometimes difficult experience is probably proportional to your outcome. The harder the work is, the deeper you go, the more emotional release you have, probably the lighter you're going to feel after the experience. So I don't think you can design the perfect psychedelic that has no dissociation that's going to give you that dramatic of an outcome. You can probably microdose some psychedelics, not get potent psychedelic effects, and have some changes in depression and anxiety. That's probably possible. It'll be interesting to see what the science shows in the next years. I just don't know if it's going to be as meaningful or as profound as the differences we're going to see in the larger doses. I think they're directly correlated dose to outcome. Okay. Where's the research taking place today? So it's happening all over the world, predominantly in the US, which is exciting. I know at Field Trip Health, we're looking at a number of different research studies, and our clinics are designed perfectly for research and patients treatment today. But what's so exciting is that all of these drugs are being studied for a whole host of mental illnesses, a lot of which we don't have good treatments for. Addiction treatment is expensive today, extremely prohibitive, and I'm not convinced that the outcomes are exceptional for the price that many people pay for addiction. So to be able to potentially use a lot of drugs, psychedelics with therapy in the right context to help people with addictions is potentially game-changing. Same with eating disorders. We do not have good treatments for eating disorders. It's one of the most difficult mental illnesses to treat. It affects just the mind and the body, and they're very difficult. So to see if psilocybin or MDMA can help with eating disorders is going to be really, really exciting. And then another area which is really exciting and which was recently approved here in Canada from the Minister of Health for 5 patients is patients who are terminal and have end-of-life anxiety or end-of-life mental illness. So the first 5 patients, I believe in Canada, at least 2 or 3 of them have been dosed now with psilocybin, and they've been granted a special exemption. Even though psilocybin is illegal, they were told by the Minister of Health in Canada that, go ahead, get psilocybin wherever you need to get it. We recognize it's illegal and you can use it. You have permission to use it for your end-of-life anxiety. So, that's going to be a snowball, and we're going to hopefully see practitioners be able to use this so that they can get the right training. Maybe that'll snowball into other patient groups being able to use it. But yeah, we need to collect the evidence. We need to develop programs, and then we probably need to, grow psilocybin, regulate it, get the right dosages. I admire that the government is letting patients use it, but at the same time, we got to also help them source it. Okay, so that's probably the next step at some point. So what does the future look like? Well, this is what I believe in. I think what's going to happen is we're going to learn with time which mental illnesses respond best to certain drugs, or which individuals can work with which drugs best for their own genetics, DNA, experiences to optimize what they're dealing with. And today we divide all our mental illnesses into all of these categories. But it's a bunch of a mixed bag, and no one person fits one box perfectly. And a lot of it's coming from the same pathophysiology. So these are much more broader in terms of holistic healing. Okay, so I'm going to just pause here for a quick second. I think we have a couple of questions, and then I'm going to also introduce Monica, our nurse practitioner. So let's just see if I can get Monica to join on first. Oh, you're here. I see you. Okay. Welcome, Monica. So I'm just going to quickly introduce Monica. I'm going to let Monica speak to the next section, and then we're going to come back and we'll do questions at the end if that's okay. So Monica Mina is our nurse practitioner in our Toronto clinic. She's the graduate of the University of Toronto's Master in Nursing program and has a history and focus on acute care. She came to Field Trip Health after working in acute care hospitals within Toronto for the past 8 years. And this is where she started to develop her passion for advancing mental health care. So yeah, welcome, Monica.
Thanks, Dr. Verbora. I'm happy to be here with you and everyone who's joining us live tonight. I just wanted to take some time here to talk about why we're doing what we're doing at Field Trip. So really understanding what the problem is. And really the problem is that our current treatments don't work for everyone. So as you can see on the slide here, about 55% of patients relapse after their second antidepressant medication. And about 4 months is the average time until relapse after a patient's second antidepressant. So that's a significant amount of time that patients are potentially struggling with mental health illness. So 6 weeks in is the average amount of time until a patient experiences a response to their antidepressant medication, if they experience any at all. The problem may also be that switching antidepressants might not be the answer. So depression rates actually increase with every antidepressant switch. So you can see on the slide here, with the first medication, there's a 40% increase, relapse rate, 55% on the second, and so on, as you can see on the screen. So what we're doing at Field Trip Health is our clinics here. This is a picture of our Toronto clinic, which is actually where I am right now. So our Toronto clinic location has 4 ketamine infusion rooms, 2 consultation rooms, and a lounge that clients can use after their journeys. We also do have clinics that are open right now in New York, and a clinic that's open in Los Angeles, and a clinic in Chicago that is set to open shortly. This is a picture of one of our dosing rooms, which is where the clients actually receive the ketamine and they go on an exploratory session, which we'll talk about a bit more in detail. But as you can see, nice, comfortable, relaxing room, zero gravity chairs. It really talks about this, speaks to the set and setting that Dr. Verbora was speaking about earlier. So the field trip program involves multiple steps. So we have a consultation phase, a preparation phase, a treatment phase, and an integration, and then beyond. And we'll go into each of these sections in a bit more detail here. Okay, so our team here is filled with experts in all of the field of psychiatry, psychology, medicine, as well as lots of researchers and advisors in Dr. Sid Kennedy and Dr. Michael Ehlers. All of these people here are experts in their field, and we're actually very lucky to have them practicing with us at Field Trip. Okay, so I want to go through our program, and this is what we offer at Field Trip Health in Toronto. So our standard program, which is called the Core Protocol, I want to walk you through each step here so you can understand what the client journey looks like. So all of our clients need a referral from their family doctor or primary care practitioner or psychiatrist. Once that referral is received, the client's booked for a psychiatric consultation with one of our Field Trip psychiatrists. The psychiatrist will meet with the client virtually to assess for appropriateness for ketamine-assisted therapy and screen for any contraindications to care. After the client's been reviewed by the psychiatrist and the medical team, the client's booked in to see a psychotherapist for an initial assessment where the client and the therapist begin to develop a therapeutic relationship and create a treatment plan. So the next step in the journey is known as an exploratory session. And that's when clients are in person to the clinic and they're sitting into those rooms that I showed you earlier. They're designed to specifically enhance the set and setting of the experience. So like I said, they sit in a zero gravity chair. We put on a nice weighted blanket, an eye mask, and a noise canceling headphone that plays specifically curated music. So in the session, the client is prescribed ketamine, and they're encouraged to really reflect inwards during the journey. The therapist is actually in the room with the client the entire time, and clients typically will have an internal journey which may involve a bit of that dissociation that Dr. Verbora was talking about earlier. So after the effects of the medicine have worn off, the client and the therapist will actually engage in a conversation and do a therapy session in the room. So the exploratory sessions typically will last between 2 and 3 hours. And the clients will have 2 of these exploratory sessions that are usually 1 to 2 days apart. So you can see the diagram there with the number 4 and the number 5. So the next step in the process is the integration session, which we talked about a little bit earlier, which typically occurs about 1 to 2 days after the exploratory session. So this session allows the client and the therapist to really discuss the material that was uncovered in the exploratory sessions and really help to integrate those experiences into the client's life. And then as you can see in this diagram, this will repeat for 3 times total. So the client will have a total of 6 exploratory sessions with the medicine and a total of 3 integration sessions. And then if you can switch to the next slide there, we do have another program. This is called our Core Plus program. Okay? It is designed to be more therapeutically intensive, and it's geared towards those with PTSD and those who may require a bit more trauma process-oriented care. The program includes 2 additional preparatory sessions and has more integration sessions built into the protocol. So a total of 6 exploratory sessions and 6 integration sessions, in addition to the psychiatric consultation and the psychotherapy intake appointment with those 2 preparatory sessions. So just a bit more trauma or just a bit more therapy focused. This process is typically a little bit slower. This program takes about 5 weeks to complete, whereas the previous regular core program takes about 3 weeks to complete. Okay, so just to give you a bit of information on what we're actually seeing in our Toronto clinic, as you can see on the slide here, the average age of the clients that we're seeing right now is 42. We're seeing clients of all demographic types, all races, all socioeconomic status, and as you can see with gender here, fairly even split. About 18 of our clients are identifying as female, 30 identify as male. And then as you can see on the graph on the left-hand side, this is going through side effects that clients experience after they've had the medicine. The dark green color there is no side effects at all. So hopefully you can see here that generally this is a very well-tolerated medication. Some of the other side effects that we have seen reported in the clinic is a lot of dizziness, some nausea, a bit of headache. Rarely have hypertension. That's basically what we have seen in our clinic so far. Okay, it's just here. Yep. I don't know if that, yep, there it is. Okay. So as you can see on this graph, this is some of our outcome data. So what we use in the clinic right now to track and kind of keep track of what people are scoring for their depression is a standardized tool, the PQH9, which is a depression self-assessment scale. The higher the number, the higher the depression symptoms are. So 16 to 20 being severe depression, 11 to 15 moderately depressed, 6 to 10 moderate, before was moderately to severely depressed, and mild. So as you can see, pre-treatment here, a lot of our clients, this is an average number of our clients, the total average of the reported outcomes are quite high in the severe levels, moderately severe to severe. During treatment, you can see that there is quite a drop, a significant decline in the amount of depression that is reported. And then post-treatment, our depression levels average is at the mild level. So that's significant if you're thinking about clients that are coming to us with the severe depression scores, and at the end of 3 weeks having, mild to almost no signs of depression. We can switch our slide. We will see here our anxiety scores. So it's similar, it's a different assessment tool. It's called the GAD-7, which is an anxiety self-assessment. Similar type of scoring to the depression. So the higher the number, the higher the anxiety scores. As you can see, our average to start off with pre-treatment, clients are in the severe or moderate range, and after treatment, you can see that they've declined almost to the mild to non-existent reports of anxiety. And with our PTSD is tracked a little bit differently and scored a little bit differently, but same type of metric, higher the number, the higher the PTSD symptoms. As you can see, there's still quite a drop in PTSD symptoms for most of our clients after the treatment. So I want to share with you a couple of things that our clients are saying. So this first quote that I can read to you is actually a client of ours who gave a quote to a magazine, earlier. So I'll read it to you. She says, "I cannot explain it, but I can tell you it was the most productive therapy session of my life. Although I had previously been aware in the intellectual sense of the traumas of my past, I have never accepted or understood how those events shaped and damaged me, making it impossible to form healthy relationships. The ketamine had somehow given the intellectual knowledge I had emotional resonance. I cried like a baby for the first time, truly understanding how events had damaged me. I could also see that every action in my present was linked to a huge amount of baggage from my past." So this is a client that we saw who had an absolutely incredible transformation. One of the other quotes that this client actually said was, "This saved my life, it saved my marriage." And it really just goes to show that in such a short period of time, this client was able to really get an understanding of the issues that she had and how to move forward with them. It wasn't necessarily a cure, and she felt better that way, but she knew how to move forward in her life. So other things that people have told us is they felt heard and seen by the clinical team. And sometimes they describe it as the first time that that's ever happened in a medical setting. A lot of people tell us this isn't their average clinic. They feel like they have direction and understanding on what they need to continue working on in the future. I thought this quote was beautiful. It was the first time this person had felt happy, the first time they can remember feeling happy. I do also remember that client specifically talking about pain and feeling that they had relief from their chronic pain for the first time in 20 years, even if it was, during that day only. The brain fog finally lifted was another very positive quote I heard. So we're seeing clients really transform in front of our eyes in a short period of time that previously when I worked in a trauma setting, I never would see these type of results. Clients would come in with, depression and would not be getting better on the typical antidepressants. And here I can actually see people changing significantly in front of me. So there's a couple of references that you can see on this page here. There's a really great book that I would highly recommend to everyone to read is Michael Pollan's How to Change Your Mind. He goes through really the history of psychedelics, his own exploration with psychedelic medication as well. There's some other great organizations, including MAPS. That you can see there's a link on the side for. It goes through a history of psychedelics, and a great resource in general just to check out it.
Okay. And if you have any questions,
Doctor.
If you have any questions, I'm just leaving our emails there. Mine is Michael at fieldtriphealth.com, and Monica's is Monica at fieldtriphealth.com. So feel free to reach out to us. So there are a number of questions. It's 8 o'clock. So if you want to hang out for the next 10 or 15 minutes, I have a list of about 10 questions that one of us has been monitoring in the chat group. So I'll kind of go through those questions one by one. So you're welcome to hang out if you want to get some answers to some of those questions. I'll do my best to answer the ones there. And if not, feel free to reach out to one of those emails, and either Monica or myself will get back to you. Okay, so I'm going to go through these questions. Bear with me a second. Okay, how do you deal with patients who have a rapid drop in serotonin after LSD trips? How do you care people through that? So yeah, we don't use LSD in our clinic. So the only legal psychedelic is ketamine, and we don't see, any rapid drop-offs with serotonin. But yeah, I think people who use high doses of some psychedelic drugs, which are very serotonergic, which could include MDMA, for example, if you take too big of a dose, then yeah, you could have that serotonin drop-off. So I don't know if there's a good answer or a good solution to that, but by and large, the research shows that in MDMA, at least, that there's not that big of a drop-off, especially when combined with psychotherapy. How do you differentiate dissociation as a result of trauma and this induced dissociation? So yeah, patients who have a history of trauma can dissociate quite a bit, and they come to our clinic. And so it's important to recognize that if patients are in too much of a state of dissociation, and they're not, overly grounded in reality, it's a fuzzy word. If they're not overly grounded, we have to be cautious about giving ketamine. So, some patients are extremely dissociated, and very disconnected, that giving them more ketamine, we fear, could actually push them in that, right? And dissociation ends up falling on that spectrum of paranoia, which can fall on the spectrum of psychosis. And then we don't want to give certain drugs to patients that cause hallucinations. So it's really important to recognize how much is that dissociation, what is the context of it. But yeah, like typically when we give you the drug, you're going to have that dissociation at some point. It may not be the first or second dose. It could be the third or the fourth dose. But it ends up being very differently. You're dissociating more from your identity and your individualism. And so we do our best to kind of monitor it. So I think it's very different. I don't know, Monica, if you have anything to add to that.
Nothing to add. I think you covered that actually really well.
Can a family doctor prescribe ketamine spray? So yeah, there's a ketamine spray available. I think technically anybody can prescribe it. It's going to be hard to find a lot of people to prescribe it other than a psychiatrist, just because it's a niche patient group of treatment-resistant depression where it's approved in. Technically they can, but I would say very few doctors are educated on the ketamine nasal spray. The regulations are also always changing, and they're actually complicated, and every province is doing something different. So there's a lot of anxiety out there from doctors. There's a lot of worries, concerns, not sure what the regulation is. So a lot of physicians, I think, who are defensive in general, are probably going to be hesitant or going to refer out to psychiatrists who might have more experience in that. But yeah, it's like cannabis. Any doctor can prescribe cannabis, but a lot of people refer to cannabis clinics because they just don't have the expertise or knowledge. It's just too much, too new, too fast. What about people who don't want to take antidepressants every day? Would ketamine be good for them? How do you define treatment-resistant depression? Yeah, so that's a great question. And I personally struggle with that, right? Because, we talk all the time in medicine about patient autonomy and patient decision-making. And then, then they come up with these guidelines that say, yeah, patients can make their own decisions with their doctor, but don't ever prescribe a drug unless they try 2 other drugs first. So it's like on one hand, our colleges and regulatory bodies say one thing about patients having autonomy, and then the other hand, they introduce guidelines that say, well, doctors need to practice these guidelines. So, navigating those two different worlds is where the art of medicine really is. And yeah, like I personally really struggle with it. Like I struggle with the notion that I have to force a patient to take something that they don't want to take because they don't think it's going to work for them or it doesn't identify with them. So I struggle with that. So I don't have a black and white answer. Like in general, treatment-resistant depression is defined as an adequate trial of 2 antidepressants for the right time at the right dose, which could be interpreted different ways by different psychiatrists, for example. But technically, you'd have to try an antidepressant twice, 2 different ones at a good dose for a minimum of 6 weeks is typically. So are there caveats to that? Yeah, there's always going to be caveats. Like some patients can't take a second antidepressant because the first one maybe made them suicidal or they got serotonin syndrome, so they should never take a second one. So we're never going to force them because it would be dangerous too. So that they would qualify maybe for ketamine. And again, there's a little bit of art there. And so if there's specific questions about specific cases, just send an email to me. But yeah, I wish I had a more definitive answer, but you know, there's a lot of guidelines out there, regulations, ketamine's considered a narcotic. And so there's a little bit of higher level of anxiety around prescribing and using these drugs. So, you know, you have to work with the practitioners, I think. And no two practitioners are going to practice the same. Living in Canada, can you speak more about the training for sitters? Are they psychotherapists? So in our clinic today, we use psychotherapists as our sitters. So they will sit with patients during that time. And, you know, many times they might not say a single word as patients are, you know, blindfolded and they have, you know, specially curated music on that's guiding them. Many instances, the therapist won't say anything. They'll just hold space for them. In other instances, patients will say, can you hold my hand? Can you put your hand on my shoulder? Like I'm feeling something intense and I just want to know that someone's there for me. And so we recognize it's so important having someone in the room for many of our patients at least. And so we provide that with our psychotherapist. And then we provide about 30 to 60 minutes, depending on how long the journey was that day, for patients to debrief to as much as they want or as little as they want. And we fill out questionnaires and we track that data for patients over time. And we find out how much did they dissociate? How much was this a mystical experience? What were your depression scores? And then what's nice about that is you can track your own progress during this journey. Anything else there, Monica, you want to add to that?
Not to that question, but nope. There's a couple more that I saw here that look great.
Yeah. Is there any that are good there that you want to go through?
Yeah, there was one here about it looks like the effects on PTSD were not as significant. And are there any explanations as to why? Does it work best mostly for depression? So that's a really good question. And so the PTSD scores that I showed on that slide, it's talking about all of our clients, not just the clients that are specifically engaged in the Core Plus program, so the more trauma-informed and more PTSD stream. So clients may not have had a very high PTSD score to begin with, and these are average numbers. So just interpret that with a bit of caution, knowing that these are averaged.
I have another question here. Is infusion or nasal ketamine more effective? I don't know that they've put those drugs head to head. I think they probably have specific and narrow indications, and they're probably like, you know, probably all ketamine, once it gets to a certain blood level, regardless of the route you take it, is probably going to do relatively the same effects. But I think it's when you pair it with the psychotherapy, you have the right setting, the right mindset, that you're really going to make the drug do a lot more for you. So it's more about the moving pieces around ketamine probably than the delivery mechanism, in my opinion. What level of education or certification is needed to apply these modalities? Well, we use psychotherapists, we have social workers, we have nurse practitioners, we have doctors. You know, only doctors can prescribe ketamine, or nurse practitioners and can administer it. And you know, we work with psychotherapists because we think they're the most qualified to help patients through a lot of their experiences. And those are kind of like, I would say, the baseline typically. I think, you know, as this widens and broadens and more research comes out, we might find that you don't need a psychotherapist in the room. Like the evidence might show that, you know, you just need a sitter or like a loved one in the room. I don't know for sure, but science will come out and evidence will come out and we'll develop, I think, the models that best match what the science shows. Are top-up doses and therapy sessions usually necessary later on? Yeah, so that's a great question. So, you know, what we call them are booster sessions. So do you need a booster session? So we don't have a lot of long-term data as a clinic, and we don't have a lot of long-term data in the literature either. So yes, the consensus in the community is that patients are offered booster doses. They're typically reassessed. We understand where they're at. We measure their scores again. And how often is that, or what doses is all art. That's the truth. And so until we develop more data and collect more data, we don't fully understand what that's like. And for every patient who might need a booster session in 2 or 3 months after their 6 sessions, we have other patients who after 4 sessions are feeling really good, and they actually just want to pause for a couple of weeks and go a little bit slower than the program requires. So again, it's very personalized, it's very customized. And while we have a program that's based on the science, we recognize that, just because that's the best science doesn't mean that's the best science for that individual in front of us. And so we look at that science, we lay it down for patients, but we adapt. And that's really important. Someone's asking about ketamine for Parkinson's. I don't think there's any science around that, to my knowledge. Lots of people are sharing things on New Dimension Radio, LSD. Thank you for sharing. I'll have to check that out. I don't see any other questions here. I'm going to just open the questions tab. Does Field Trip offer psychedelic integrative therapy services for those who do not qualify for the ketamine program or are in the ketamine program but are interested in finding this type of counseling? Yeah, that's a great question. We don't today. So, there is a growing movement for what we call harm reduction psychedelic integrative therapy. So there's definitely a movement in the psychotherapy community where psychotherapists feel comfortable helping patients. We don't do it externally. Our model is very inclusive and modeled to the ketamine and the dosing. But yeah, ask us in 6 months or a year, I don't know. It could change. This is a very rapidly changing field. And it's a little bit challenging, right? Because while patients are trying to use maybe some of these drugs on their own to get better and then have therapy, which I think is wise, those drugs are illegal. So it's finding the right way of getting around that to also hold yourself to the professional standard that you're expected to. So it's a challenging act as well. Does the Toronto clinic use ketamine or do you use psilocybin? So we only use ketamine, just because psilocybin is not legal. I don't know if there's any other questions. Do you see anything there, Monica?
It's a good question about insurance companies being receptive to issuing ketamine as a treatment. So it's definitely an area that we are working on. We have an active outreach team working with insurance companies right now. I can tell you that clients do tend to have, if they have psychotherapy coverage or social work coverage, a lot of the psychotherapy sessions can be covered depending on your insurance plan. But in terms of the ketamine and the medicine itself, that has not been able to be covered by most of the plans, to my knowledge, at this point. And I think other questions, I did see someone asking about masks and if masks affect the bonding with clients at all. I think it's a really good question, especially in this time. And, clients, unfortunately, right now with COVID are to wear masks when they're inside just to comply with the guidelines put out in Ontario. But I think what we've done with the virtual sessions for integration has really helped with the bonding. You get to see the face, the whole client, since when they're in the clinic, you really don't get to see their face too much. But it doesn't seem to have been an impact in the bonding relationship between the therapist and the client at all. And I don't know if I see any other questions here.
I don't see much. I'm answering a couple of questions in there as well, and I'll hang around for 5 minutes after. I'll disconnect, but I'll answer some questions in there that are more specific. Okay, so I think maybe we can end it here on that note. And so once again, thank you so much for taking time out of your busy lives and just spending the evening with us and hopefully learning a little bit. And please, reach out to us. You have our emails there. We're going to upload this to our YouTube channel as well. You'll be able to review it all and have access to it. Just don't hesitate to reach out. This is a community. This is something we're building. And we know that, having these conversations is what's so important and necessary to making this accessible, and education is that first piece. Thank you. Have a good evening, everyone. Take care.